Good evening, everyone. I'm Priyanka Sethi, working at Development Monitoring and Evaluation Office, DMEO, Niti Aayog. I would like to extend a very warm welcome to you all to the second session of the DMEO Conversation Series, a platform aimed at bringing together the leading monitoring and evaluation practitioners from the international development organizations, academia, think tanks, NGOs, social enterprises, investors, and other private sector firms, including technology firms and CSR wings, to discuss theory and emerging practices in the field of M&E. Today's session is being conducted in partnership with the International Initiative for Impact Evaluation 3IE, a global leader in producing and synthesizing rigorous evidence and an advocate for the generation and use of quality evidence in development decision making. So before moving further, I would like to run everyone through the housekeeping rules. We will start by introducing our speakers, which will be followed by their presentation, and we will be taking up the audience questions at the end of the presentation. As this is a webinar format, the participants have been muted, but we'll take all your questions through the Q&A module. So please feel free to use the Q&A option available at the top right-hand corner of your screen and then tap on Ask a Question. Here you may type in your questions with your name and organization name in the chat box so that we can take them up seamlessly. Having said that, and since this session is time-bound, we will try our very best to address all of your questions. However, if your question still remains unanswered, please write to us on dmeo-partnerships@gov.in. The email ID is also there in the chat box for your easy reference. Also, please note this session is being recorded for DMEO record purposes. All right, let us now begin today's session with the introduction of our speakers. It gives me immense pleasure to introduce today Ms. Stuti Tripathi and Ms. Pooja Sen-Gupta, the two stalwarts of the 3IE team. So Ms. Stuti works at 3IE as an evaluation specialist and currently leads its engagement in the Philippines. She has expertise in areas of livelihood, microfinance, and nutrition. She has worked extensively on issues of research uptake and currently sits on the Data Monitoring Evaluation and Learning Technical Expert Advisory Group of the UK Department for Business, Energy and Industrial Strategy that advises on two of the largest overseas development assistance funds. Prior to 3IE, her work at International Finance Corporation focused on promoting practices in responsible financing in the Indian microfinance sector. Our next speaker is Ms. Pooja Sen-Gupta. She is currently engaged as a Senior Research Associate with 3IE and provides research, coordination, and capacity building support for several projects in the organization, focusing on livelihoods and nutrition. Prior to joining 3IE, Pooja worked for the National Institute of Rural Development and Panchayati Raj, PricewaterhouseCoopers, and Indian Institute of Public Administration. She has over 6 years of experience in livelihoods and gender research, field research management, and building technical capacities of state governments and project implementation agencies. Now, without any further delay, I would now hand over the platform to Ms. Stuti.
Good afternoon, everyone, and thank you, Priyanka. Thank you, DMEO, for actually giving us this opportunity to present at the conversation series. Pooja and I are thrilled to be here and to be presenting to such a distinguished audience. As Priyanka mentioned, we will be sharing today a gap map that we created for implementation research on nutrition-specific interventions in India. This is some work that we did with IFPRI India office, and the findings from the study were actually just recently published in August 2020. The report that you see to your right on the screen is the report that's from the study, and it can be easily downloaded from 3IE's website. Though Priyanka did provide an introduction to 3IE, I think I'll just quickly add on to what Priyanka already mentioned. So 3IE, or the International Initiative for Impact Evaluation, what it stands for, is an international NGO, and we are basically in the business of promoting evidence-informed policies and programs through generation and use of high-quality evidence. Since our inception in about 2008, we funded evaluations, over 250 evaluations across 50 low and middle income countries. So with that, I will drive straight into the study that Pooja and I are presenting today on behalf of our co-authors. Next slide, please. So Pooja and I did this study along with our co-authors Abhirupa Das, Varigada, and Urmi Bhattacharya, and they might be in the audience if they've been able to make time for it. Next slide, please. So before we actually dive into, what were the findings from our study, we thought it might make sense for us to just walk the audience through the concept of an evidence gap map and how does it typically work. So what an evidence gap map basically does is that it consolidates evidence in a particular sector, which in this case is nutrition. And this consolidation actually entails sifting through large volumes of literature to find studies that fit the population, the intervention, and the outcomes that we are interested in. Now the words population, intervention, and outcome are key here, and we'll actually be talking more about it in the context of this implementation research gap map later in the presentation. So once it's actually consolidated the studies which speak to the population, intervention, and outcomes of interest, what the next step that the EGM or the evidence gap map basically does is that it visually displays this evidence onto a matrix, an intervention and outcome matrix, and produces what we call the gap map. And this gap map can actually be a very useful tool for policymakers, practitioners, researchers, commissioners of research who want to quickly see where is it that there are gaps, where is it that there are gaps in evidence, and where is it more work and more research needs to go in if we are to have policies and programs that are funded by or that are at least informed by research and evidence. Next slide, please. So what the next slide is basically doing, I've just used a sample of an existing evidence gap map that 3IE did. As you would have guessed, looking at your screen, this is a gap map of WASH interventions. And on the y-axis, which is the vertical axis, we have the interventions, and on the x-axis, which is the horizontal axis, we have the outcomes. So how does one read this gap map that you have displayed on your screen? Say, for example, if you pick up the intervention that's highlighted on your screen, which is the health messaging intervention, what this gap map will basically tell you is that how many studies are there that look at health messaging as an intervention and look at the impact of health messaging on the various outcomes that are listed on the x-axis. So, for example, the outcomes that we've highlighted here is diarrheal disease and willingness to pay. So if you focus on those two outcomes, you'll see that if you were to focus on the one that's on diarrheal disease, you see a green bubble down below. And that shows the quantum of literature that's available, which is talking about or which is studying health messaging interventions and trying to assess the impact of health messaging interventions on the incidence of diarrheal disease. Just next to it, you see a circle in red where there is no bubble, and that's what actually is denoting is that there is actually no, or I shouldn't say there's no intervention, but there's no intervention that has been studied which looks at the impact of health messaging on the willingness to pay. And this could be communities' willingness to pay for, say, community toilets. So what? And one thing that we are actually not being able to depict on this map because it's a static picture, but if you were to go on 3I's online platform, if you were to hover over these bubbles, these green bubbles that you can see on your screen, it would actually give you a full list of studies that go behind creating this bubble. So all the studies that look at health messaging intervention and its impact on diarrheal incidence of diarrheal diseases would get listed if you were to hover over that bubble, and these links are actually clickable. So you click on a particular link and it will directly take you to where that study is and where you can access that study. So what However, I think it would be important to point out here is that what this gap map doesn't do, or what the 3IE gap maps don't do, is that they don't tell you the direction of impact. So while you can say that, okay, there is enough evidence to say that, about health messaging interventions on diarrheal diseases, on the impact of health messaging interventions on diarrheal diseases, what it doesn't tell you is that whether those interventions had a positive impact, negative impact, or did not have any impact at all. So that aspect is not covered in the gap maps that we put together. So I think this is the kind of, just to sort of explain to you conceptually in terms of how gap maps that 3IE puts together work. Could we go to the next slide, please? So what is it new that we have done, that we've been able to put together? Gap maps have been around for probably a decade, and 3IE was in fact one of the pioneers in putting evidence gap maps together and sort of visually depict the underlying evidence database on a particular theme or a sector. However, what you would see, if some of you are familiar with evidence gap maps and have tried to sort of tinker around with it to see what is the kind of underlying evidence behind these gap maps, what you would find is that a majority of evidence gap maps actually look at effectiveness outcomes. So as you would see on the slide, there is the intervention that or a set of interventions that an evidence gap map is interested in, and it would plot those interventions against the outcomes that, once again, define the scope of the gap map. What these gap maps typically don't do is, what is it that causes these interventions to have an impact or to not have an impact? And this is what we call the black box of mechanisms. So what are the underlying mechanisms that cause the interventions to have an impact or not to have an impact is often not sort of unpacked in these gap maps. And this is where implementation research actually becomes extremely critical, because here is where implementation research actually sort of looks into the mechanisms. And on the slide, if you see, we've listed a few mechanisms just for illustrative purposes, like stakeholder characteristics, intervention delivery quality, contextual barriers and facilitators. And some of you who've been in the development sector for a longer time would really relate to some of these factors which determine the success or failure of an intervention. And effectiveness literature often doesn't look into these things, which is where implementation research sort of has an important role to play in unpacking the mechanisms that underlie between an intervention and the kind of outcomes or the impacts that we see that intervention to be having. So at least to our knowledge, this is probably the first country-focused implementation research gap map that we are aware of. Next slide, please. So so just going back to, if you remember, I had mentioned that the scope of an EGM is primarily decided by three things. What are the interventions it's going to be looking at? What are the outcomes it's going to be looking at, which create the X and Y matrix? And then what is the population that it is interested in? For the evidence gap map that we are presenting today, the implementation research gap map, in nutrition specific interventions that we were interested in were primarily fell into 5 categories. We were interested in looking at interventions on supplementary feeding, food fortification, micronutrient supplementation, behavior change communication, and some other interventions like management of severe acute malnutrition, delayed cord clamping, and weight during pregnancy. And the way we arrived at this list of nutrition-specific interventions was actually through a process of extensive stakeholder consultation, where we got together in a one-day workshop called, nutrition experts and nutritionists into the same room and tried to sort of deep dive into what are the interventions that would be of interest for this particular implementation research gap map. And as you would see, these interventions actually also speak directly to the Poshan Abhiyan or the National Health Mission of the Government of India. Next slide, please. On the outcomes, we actually categorize the outcomes, which, if you remember from the gap map that I showed you, is the X-axis, we categorize the outcomes into three broad categories. This is the program level outcomes, the health worker level outcomes, or the participant level outcomes. And within each of these big categories, we have a whole list of, if I may say, sub outcomes that we look at, and we code all the studies across this range of outcomes. So just for ease of understanding, say if we take participant level outcomes, so every study that we looked at, we coded for whether it talked about coverage of the participants, what was the level of acceptability of the intervention among participants, what was the level of knowledge about the intervention, did they find it feasible to access the intervention, and what was their uptake and compliance. And similarly, both for health workers and at the program level, we looked at each of these outcomes for every study that was included. And then there were these cross-cutting themes, which we put as barriers and facilitators, because what we tried to look was that if a particular study set had a particular finding about whether or not the participants had took up a service or were compliant to the schedule that they were provided with, whether or not they did it, what were the factors that either facilitated or inhibited that behavior. So those were some of the cross-cutting themes that we coded for across all the studies. Next slide, please. So this is how, this is just an implementation framework which sort of fits together all the aspects of the study that we were looking at. So on the left, on the extreme left, as you would see, are the list of interventions. Though here, I think what I would like you to focus on is the last category, which is the bundled interventions. If you remember, we didn't have this as the category among the 5 original categories that we had set out for ourselves when we started putting this implementation research gap map together. However, as we went through more and more literature, what we realized was that there was this very important category where there were a lot many papers that looked at system level outcomes. So, for example, there were many studies that looked at, whether the Anganwadis had growth charts or not, or whether they had weighing scales or not, or whether those weighing scales were functional or not. And we thought that those were important things to capture as part of implementation research. So we sort of added this category on to so as to not to lose out on that very important literature, which would then at the program level look at adequacy or sufficiency of resources. So the other thing that we found was that a majority of these interventions, the nutrition specific interventions that we were interested in, were primarily delivered through 4 platforms actually. ICDS, I'm sure that's no surprise for people who are familiar with nutrition specific intervention in India, that ICDS was an important platform for most of the studies. Then there were studies that looked at National Health Mission, a delivery of nutrition specific interventions through the National Health Mission. Then in health system, we basically coded for studies that may not necessarily have mentioned that, whether this was National Health Mission or not, but maybe were services delivered in a hospital setting or even a primary health center setting. And then finally, the self-help groups also emerged as one important delivery mechanism. So these were primarily the 3-4 channels which most of the literature seemed to suggest, or was at least the best studied among the literature that got included in our evidence gap map. And we looked at that literature to see what was the level of, or how the outcomes on the program level and the FLW level performed. And then the actual delivery to the participant was basically through, whether it was through home visits, facility visits, in some cases it was both, and how that affected participants or the beneficiaries' participation, and eventually leading to whether or not it had an impact on their nutrition status. For studies that did talk about impact on nutrition status, we did code for it, though I should say that, that was not really our first mechanism of was not our inclusion criteria, because our focus was not so much effectiveness outcomes as it was implementation outcomes. Next slide, please. And here I think we come on the third critical aspect, the population. So the target population was initially, when we started out, we initially were looking at pregnant and lactating women, mothers with children below 2 years of age and children below 2 years of age. However, we later actually expanded this category to include three more categories. And this was children 0 to 6 years of age, mothers of children 0 to 6 years of age, and frontline workers and health workers. So one reason why we expanded this category was, as I mentioned earlier, there is a lot of literature that looks at ICDS or that studies the ICDS program. And many of these papers didn't really, what I should say, parse out the population into 0 to 2 and 3 to 6. And they generally just bucketed it into a category of 0 to 6. And we thought that if we were to very stringently stick to only 0 to 2, we would lose out on a whole range of literature that's actually, once again, speaking to important implementation outcomes of ICDS program, but because they're looking at 0 to 6 category, they don't fit our population, and we would just not be able to code for those studies. And once again, as we went through more and more literature, we realized that there is actually a significant volume of literature that looks at frontline workers and health workers. And given the key role health workers and frontline workers play in the delivery of services, and given that implementation research, that is the focus, understanding the delivery of an intervention is the focus of implementation research, we decided to add that as a category to make sure that we were not missing out on important outcomes. Next slide, please. So how did we go about actually searching for literature? As this slide basically gives out our strategy for how we went about searching for literature, which was to be included in the EGM. So once we had our population, our outcomes, our target population, and our intervention sorted, we basically searched for this literature in 13 repositories, and at the same time we prioritized repositories which we knew had a health focus. So on the right on the slide you can see the list of repositories that we ran searches on. These were electronic searches, so we came up with keywords, we strung them into search strings, and then we ran these searches in all of these 13 repositories. And against that, you can see the number of the amount of literature that each of these repositories actually threw up. Then, aside from running electronic searches, we also realized that a lot of implementation research, especially for implementation research, a lot of the literature might actually be resting in might be unpublished or gray literature. And so as to make sure that we capture this important literature as well, we hand searched about 32 websites. These were primarily websites of organizations that have an important portfolio in health and nutrition. So we would go to their website, look at their resources section, look at the publications, and see which of their publications actually fit into our intervention outcome and target population. And then the third step that we actually used to sort of collect more literature was to sort of speak to experts, nutrition experts, and use a sort of a snowballing approach to know where they might be thinking, where they could guide us to speak to some other person, and gather literature in that sense. Next slide, please. So based on that, we actually ended up with about 24,000 records, both electronic and searches and manual searches together added up to about 24,000 records, which, after removing for duplicates and then screening both title and abstract and later full text against a well laid out inclusion and exclusion criteria, left us with about 368 unique papers that were then included in our gap map. So at this point now, I'll hand over to my colleague Pooja, and she's going to walk us through the findings from our exercise. Thank you.
Very good afternoon to all of you again. So in the next set of slides, we'll discuss some of the key findings from this study in some more detail. Next slide, please. Right. So in this graph, we have plotted the papers by year, and we find that there is an upward trend with an increasing number of papers examining implementation outcomes over the years. And as you can see, the trend is not uniform across the years. Nonetheless, it is encouraging to see that there is a fairly steady increase. Just a clarification here, for this study, we only included papers that were published between 2000 and 2018. Next slide, please. Okay, so in this map, we've tried to show the spread of literature across the country. And in terms of distribution of papers across the states, the evidence is encouraging because we find that there is some evidence across all states. But in terms of the magnitude of evidence, Uttar Pradesh, Gujarat, Bihar, Odisha are the 4 most studied states. In terms of the least studied states, we find that the states in the Northeast still remain neglected, with only 7 papers that look at the interventions in this region. Some of the other states that we found were we had comparatively lesser evidence were Himachal Pradesh, Jammu and Kashmir, Telangana, and Kerala. Next slide, please. This slide is, it just shows us the same evidence that's displayed in the earlier slide, but in terms of the number of studies that we found for each state. So as you can see the red bars, these are basically states with more than 30 studies each, and UP, Gujarat, Bihar, and Odisha are again some of the most studied states. With less than 5 studies, we find the states of Mizoram, Arunachal Pradesh, Goa, Manipur, Meghalaya, Nagaland, Sikkim, and Tripura. They're the least studied. I would just like to clarify here that you can also probably see the black bar in between. So here what we did was we also included studies which may not have made mention to different states in India, but have studied India as a whole. And there were 34 such studies. Next slide, please. Okay. So in this figure, we provide a breakdown of the target population for the included papers. And as Stuti has already mentioned, our target population was pregnant, lactating women and children under 2 years of age. Basically, we try to look at nutrition outcomes within the first 1,000 days of life, which is roughly between conception and 1 second birthday. But we also expanded, this target group of 0 to 2 years to 0 to 6 years. So that is why in the bars, in front of you, you'll find that there is a category called children under 2 years of age, and you will also find children other age. So children other age is basically when we found we coded for studies which were looking at target population that was 0 to 3 or 0 to 4 up to 0 to 6. So a total of 175 papers look at FLW level outcomes like coverage, acceptability, knowledge, etc., making it the most studied target population. And from the bars, it is evident that the primary target populations like pregnant, lactating women, children under 2 years have been well represented in our literature. Next slide, please. Yeah. So this is basically evidence distribution by delivery platform. And as Satish noted that under delivery platforms, we've coded for ICDS, National Health Mission, self-help groups, healthcare system, and other platforms. And for healthcare system, she's mentioned that whenever it was a hospital setting or a primary healthcare setting, that either predated the National Health Mission or do not make any specific reference to it, that's when we have coded those papers under healthcare system. So we find that ICDS is the most studied delivery platform, with almost 66% of the papers looking at ICDS as one of the delivery platforms. Now, considering that ICDS is one of the largest programs in India, and it reaches out to 20 million pregnant and lactating women and 82 million children, this finding is probably not very surprising. Next slide, please. Okay, so before we deep dive into the gaps in implementation outcomes or the interventions that we have studied, we just wanted to highlight a challenge that we came across during the initial phase of screening and coding the literature. What we found that there was lack of description of interventions in the studies that we examined, and this is this lack of clarity in the description of interventions was in roughly a third of the total papers that we had coded. Now, a discussion of program design and rollout, it is a very important prerequisite for research that seeks to assess some aspects of implementation research. And that is why this was quite a challenge for us. Now, we found that this lack of clarity in the description of implementation, design, and rollout, this was, it mostly included papers that describe ICDS and NHM, National Health Mission. And for example, we came across studies where the paper does not detail the activities performed by the Anganwadi worker, but later goes on to measure implementation outcome indicators such as, say, the number of home visits made by the Anganwadi workers, or number of Anganwadi workers maintaining books of records. So now, so one of the explanations could possibly be because ICDS is a very well studied program, and many authors may not have felt the need to sort of go into details about program description, because program descriptions of ICDS and NHM, these are public, publicly available. But for a study like ours, it was quite a struggle to sort of reconcile these issues that we faced. Next slide, please. So in this slide, we present the evidence that is available on the interventions in our study. So as you can see that behavior change counseling is the most studied intervention. And within behavior change counseling, we have the most studied interventions for breastfeeding counseling, followed by growth monitoring counseling, and counseling on complementary feeding. Then micronutrient supplementation was also fairly well studied, and this was largely driven by the literature on iron and folic acid supplementation, which accounts for about 50% of the total papers that we found in this category. So in bundled interventions, as Stuti has mentioned, we categorized papers that specifically did not look at any one intervention. And there were 382 such instances where we coded for bundled interventions. So these were the most studied. Now, in terms of the least studied interventions, we find that management of severe acute malnutrition, then weighing during pregnancy, and delayed cord clamping to be the least studied. Next slide, please. Okay. So in this slide, we've tried to present the evidence that is available on implementation outcomes that we have studied. So as you can see, participant level outcomes, they're the most frequently studied. And we coded for implementation outcomes a total of 1600, roughly 1600 times, out of which 51% constitute outcomes at the participant level, followed by FLW level outcomes at 26%, and then by program level outcomes at 23%. So participant level outcomes were coded across, 5 implementation outcomes as Suti's discussed, which is acceptability, coverage, feasibility, knowledge, and uptake. And we found that coverage, participant coverage, and uptake were the most studied outcomes. For participant coverage, receiving a service was the primary indicator. And to give you an example, it includes factors such as receiving breastfeeding counseling, or receiving micronutrient supplementation like iron and folic acid, or say being weighed during pregnancy. So receiving a particular service is basically the primary indicator for coverage. But uptake is slightly different, where we measure the actual consumption of the supplements, or any changes in the nutritional and feeding practices based on all this counseling that is being received from the FLWs. So coverage and uptake at the participant level, these were the most studied. At the FLW level outcomes, compliance and knowledge are the most studied outcomes, and very little attention actually has been paid to any of the other FLW level outcomes like time use, motivation, quality of engagement, etc. At the program level outcomes, we looked at these 5 implementation outcomes that you can see: program adequacy, access, targeting, monitoring, and program cost. So we find that adequacy of resources is the most studied, closely followed by the cost, program cost. Now, though it is a little worrisome that all these other outcomes have not been very well studied under program program outcomes, and these are very important ones. An important precondition for how a program performs with regard to other indicators is determined by adequacy of resources, and this has been studied quite well in the literature that we see, and so it forms a very important piece of information from the program implementation perspective. Next slide, please. Okay. So this interventions and outcomes matrix is basically this table summarizes the information from the earlier 2 slides, and the gaps in literature, they are highlighted in red, and the green cells basically show where there is ample evidence. So as you can see, there is almost no evidence on delayed cord clamping, severe acute malnutrition, and fortification at all implementation outcome levels. And the most studied interventions for all outcomes again are behavior change counseling and micronutrient supplementation. So now we have a fairly good idea of where the gaps are in both the implementation outcomes as well as the nutrition interventions. But in order to, for implementation research to contribute to, efficient program design or to facilitated evidence-informed decision making, it needs more than just filling up of these gaps, because from our study, what we gathered was that the primary objective of large body of the literature was not to study program implementation. So the studies do not systematically capture the outcomes that are studied through a theory of change or a programmed causal chain, and hence they provide very limited insights to the factors that actually affect program implementation. As we have already discussed before, you can see that there's a preference to study implementation outcomes that are easy to measure, like coverage and uptake, which are you can find these on the MIS sheets or the monitoring tasks of any intervention. So to give you an example, we studied 17 total outcomes, and out of that, the 5 most studied were participant uptake, participant coverage, FLW level knowledge, FLW level compliance, and program adequacy of resources. Next, yeah. So just sort of following up on the same discussion, we coded barriers and facilitators because they are very critical in explaining the failure or success of program implementation. And what we see is out of the 1,500 times that we have actually coded implementation outcomes, barriers and facilitators were coded 150 times, which is roughly 9% of the total times we coded implementation outcomes. And even within this 9%, facilitators are studied even less. Out of these barriers, that we have coded, we found that there were no papers that studied barriers for delayed cord clamping and weighing during pregnancy. Next slide, please. Yeah. So I think we can conclude, the finding section of this presentation by suggesting some priorities for future research based on the findings of this study. So we think that national and state governments, they should develop high priority research questions and which would entail closing gaps in not only just under-researched topics such as fortification, weighing during pregnancy, and delayed cord clamping, but also generate context-relevant evidence in underserved states. There is also a limited attempt to understand whether these implementation outcomes actually vary by demographics or within a targeted group, and these gaps in coverage equity need to be better studied. Then we've already discussed this before, that there is a clear preference to studying implementation outcomes that are easy to measure and are tracked as a part of monitoring any program. So there instead needs to be more focus on studying the full spectrum of implementation outcomes that have a bearing on program implementation. There is an urgent need to remedy all these issues that we have talked about by producing high quality implementation research that focuses on implementation fidelity and the barriers and facilitators that actually lead to the failure or success of any program. From our study, 2 things became quite apparent. One is that there is no set benchmark on what constitutes good implementation. For instance, the percentage of what percentage of coverage is good for a particular intervention. Secondly, most of the papers included in the study, they don't draw direct causal links between implementation outcomes and nutrition outcomes, because we find that there seems to be not enough emphasis in studying the programmed causal chain, which leads to certain nutrition outcomes. So addressing these 2 gaps, we find will be an important contribution towards implementation research in nutrition. Now, lastly, I mean, using these gaps, we of course have to look for appropriate areas of collaboration and future funding, and we should try and create adequate mechanisms to ensure that both government and non-government program implementers are actually using the available implementation research, and that there are strong linkages between implementers and researchers to support topically and geographically relevant nutrition implementation research. Next slide. So this is basically the sum total of all our work. So the implementation research gap map. We have the link. You can basically use this link and navigate this implementation research gap map. We also have the same page has links to our working paper and the brief, and it would be great if you could look at all these three and provide us your feedback. I think I will. That's all from my end, and I hand it the remainder of this presentation to Priyanka.
So thank you 3i team for a very insightful and an interesting presentation. So next we will move on to taking up questions from our audience. So I would like to begin first, like I had a question. So regarding your search strategy for papers, you mentioned a number of repositories, websites and experts. So I was just curious to know, did you follow, like, how did you come up with the numbers? Did you follow any particular scientific methodology to come up with the numbers?
Sorry, Priyanka, I think just small clarification. When you're saying numbers, what numbers are you referring to?
So you told that you chose 13 repositories, and then there were a number of experts which were
okay, those numbers you're talking about. Okay, so I think what we do is we basically have a long list of repositories that we typically go back to when we are picking up EGMs in different sectors. And what we try and do is we do some level of prioritization. So if it's a EGM that, say, which was the case with this one, which was more aligned to health and nutrition, we prioritize looking at repositories that have a health focus. And so it's not really, we don't decide a priori that we want to get into, or we want to be looking at 13 repositories, or we want to be looking at 15. It's more what is relevant for the purpose of, or the scope of the EGM. And similarly, both for also for how many organization websites do we want to go through. So we would make a long list of organizations, also through a consultation with various stakeholders in terms of which are the organizations which have a significant portfolio in health, and it would make sense for us to sort of go into their websites and try and see. So these are just numbers that got added up later. It wasn't really so much a target for us to say that we want to do at least 30 organizations or at least 10 repositories. So this is just an addition. This is how our effort sort of adds up, not something that we decide a priori.
Thank you, Stuti. Thanks for that. So next question, we have a very interesting question from Mr. Vijay from World Food Program. Can the evidence gap map methodology be customized for programs that have undergone internal or rapid assessments as opposed to peer-reviewed evidence? For example, departmental reports that are high on frequency but low on evaluation rigor.
So in this particular case, actually, we have included that kind of evidence, and that is the kind of evidence which actually a lot of sifting through organization websites threw up a lot of that kind of literature. So unfortunately, the field of implementation research is still evolving, and a lot of methods that are used in the field of implementation research are not very rigorous. So what we also decided, and this was a sort of a call that we took as we were going through more and more literature was that if we set our bar very high in terms of, what qualifies as good literature, we probably would end up with a really small pool of studies. And at the same time, I think it also meant us taking a call that probably implementation research, unlike say maybe if you're looking at impact evaluations, don't require that level of rigor and that level of vetting of quality as maybe implementation research probably doesn't require that level of rigor or those high benchmarks of rigor as probably an impact evaluation or an effectiveness EGM would need to employ. So at somewhere, because this was something we were doing the first time, and this work actually therefore also took much more time than we had actually anticipated, because these were things that were not really laid out for us in a protocol, and we sort of made strategic choices as we went along in terms of how high to set the bar. I think the minimum that we wanted to make sure was that we came across a lot of papers that we thought were sort of if you papers that do a discussion about a particular nutrition issue, or papers that have a commentary on nutrition issues. We wanted to make sure that we only include literature that are which is evaluating a particular intervention using a particular methodology. What we did, the next step that we didn't go was how rigorous that methodology was, partly also because we thought of it as slightly less relevant in the context of implementation research compared to impact evaluation. Pooja, do you want to add anything there?
So to just add on to that, I mean, 3I has, its own set of guidelines for even including impact evaluations for these EGMs. So because this study was first of its kind, and we had to hash out all these issues that Stuti has already raised, we have actually made these strategic choices where we have probably loosened up the criteria a bit.
Okay. So moving on to the next question. So it's from Mr. Anil Pimpel. He asks, as per the chart, it seems that states like UP, Gujarat and Bihar have more research papers on the nutritions. Do these research papers have the same state as a study area?
I'm not sure I understood the question, Priyanka. Sorry, could you please repeat it?
Sure. So yes, as per the chart, it seems that states like UP, Gujarat and Bihar have more research paper on nutrition. Do these research papers have the same state as a study area?
So the way we have mapped papers to states is that when they say that this was a study say conducted in Unnao district of or Barabanki district of UP. So if the paper specifically says that this is the district in which of UP that a particular study is taking place, we would code that paper as UP. However, as Priyanka, as Pooja said, that if the paper makes no mention of a particular state and is taking a more all India perspective, we just mark it as at the level of India. I hope that answers the question, because I'm not sure if I got it right even on the second attempt.
Okay. So moving on to the next question. So Mr. Salam Singh has a question. He asks, do the research papers under consideration also include regional language or taken only in English? State-wise comparison based on absolute number of papers is misleading as the size of states are different. Don't you think that there is a need for normalization?
So yeah, I think that is a point that we should have made. We were actually only able to include papers in English. So that was actually an inclusion and exclusion criteria. We could not take up papers that were either published in Hindi or any other regional language. In terms of statewide comparison, I think while we have not tried to do it very systematically in terms of saying that, what is the proportion of papers to the state population, what we do see from a very cursory comparison is that it is in fact the most populous states that also happen to be the most studied. So I think somewhere in the report we've tried to make that comment in terms of X percentage of India's population residing in states that also happen to be the most studied. So, UP, Bihar, Maharashtra, they also happen to be the most populous states, but we haven't done this comparison systematically across all states to see, how does the population of the state compare to the proportion of the studies.
Okay. So moving on to the next question, Stuti. So again, Mr. Vijay from World Food Program, he asks, what are the challenges the team faced in communicating findings from comprehensive EGMs to audiences with limited exposure to evaluations? And he further mentions, like, what are the solutions that can be used in this context?
So I think this EGM actually has been better for somewhat of to communicate to a non-technical audience. I think we run into more issues when we are presenting EGM, which is talking about effectiveness outcomes, and when we say that the only literature or the only evaluations that we've looked at is impact evaluations. And that in some cases we realize is not very well appreciated among people, because they say that there's a whole lot of other literature that's out there which probably should be considered. So I think that is a challenge that we have faced more when we are talking about effectiveness EGMs rather than the implementation research EGMs. However, at the same time, I'm sorry, Priyanka, I missed the second bit of the question. What was the second bit?
Yeah, it was. What are the solutions that can be used in this context?
I think this. I think one thing that I think there are two areas where we feel that implementation research in nutrition needs to move, and probably that is something that requires a more synergetic action between researchers, practitioners, and policymakers. And I think so. Just if you recall the last slide, that the concluding slide that Pooja presented, I think one challenge that we would really like to highlight, because it was a challenge for us as we were trying to sort of put this EGM together, was the field of implementation research in itself. What we feel is that the field of implementation research needs to evolve much more than the stage at which it is. And talking about some of the not only the methodological challenges, but also things like if I recall, just going back to Pooja's last slide about what constitutes good coverage, what constitutes good access, what is good enough uptake, and at what point do we say that okay, if is 70% good coverage, or nothing less than 100% is good coverage. So that also poses a challenge in terms of the use of implementation research. One is, of course, the field needs to evolve. The methods in the field have to evolve and have to become more rigorous. And the second is the application of the findings, which at least we couldn't come across any literature where the paper ended on a note that okay, this is good enough coverage, even if at 70% this is good enough coverage. So what lessons for policy and programming should we draw from what we are seeing as findings from the implementation research? Probably is a subject of greater deliberation.
Yeah, thanks, Stuti, for that. So our next question is from Mr. Subhash Nigam. He asks, like, how much time does it take in bringing out improvements through behavior change intervention?
Unfortunately, that's not an outcome that we've coded for, because that sort of goes into the realm of effectiveness outcomes. So maybe an effectiveness EGM, which is looking at, but though, like I said, even an effectiveness EGM, we typically would not basically inform you what is the direction of impact. So if you're looking at, what was the impact of behavior change interventions and actually changing the behavior, an EGM will actually not be able to inform you on that question. what would be able to answer that question is probably a systematic review, which would sort of synthesize findings from across various studies that are studying behavior change communication interventions and tell you the direction of impact, and also, you know, do a meta-analysis to tell you an aggregate impact. Unfortunately, EGMs are not the best tool to answer that question, and that is more an exercise that a systematic review can effectively answer.
Okay, so thanks, Stuti. And also thanks, Ms. Pooja, for answering the questions so elaborately. So we still have a number of questions left, but we are moving close to the scheduled end. So, however, to the participants, if your questions still remain unanswered, I would again like to request you to please write to us on the email ID provided in the chat box. Before concluding, I would now like to thank the 3IE team and the speakers for collaborating with us and being a part of this DMEO conversation series, and for sharing their valuable insights and learnings. Also, I would like to thank the DMEO conversation team members for all the background work, and the senior leadership for constant support and guidance. And last but not the least, very important, our audience for attending and participating actively. Now, to conclude, if you liked this session, or maybe did not like something in particular, or if you want to see more of it, please do watch out for a feedback link that will be emailed to you by DMEO Conversation team. We will be waiting for your feedback, so do write to us. As we close, I would like to share that it is our constant aim to share and discuss the emerging practices and research in the M&E domain through the DMEO Conversation series. We will soon release a notification regarding the next session, so please be on the lookout for the same on our website and the official social media pages. Also, if your organization wishes to collaborate with us for conducting a session through the DMEO Conversation series, please write to us. So finally, a very big thank you to one and all, and see you next time.
Thank you, everyone.
Thanks, Priyanka. Thanks, Shubham. Bye.